Okay, good morning, everyone. Thank you for joining today's webinar on RadxTools, Pixels to Predictions, Designing Computational Imaging AI to Enable Precision Medicine. This is Kayla Strauss. I will be facilitating the WebEx today. Please let me know if you have any issues with your screen or audio. So this is one of a series of webinars on ITCR tools that CBIIT has scheduled for the NCI staff, and we certainly hope that these tools might be useful to your research. Of course, we wanted to let you know that we are recording this session for future reference. During the session, if you do have any questions, please use the chat function to type your question, and we will be answering questions at the end during the Q&A portion of the webinar. Feel free to put your questions in the chat during the presentation. We'll just hold them towards the end. Let's see here. So without further ado, here is Dr. Satish Viswanath. Go ahead, take it away. Thanks so much.
Absolutely. Thank you guys so much for having me here today. My name is Satish Viswanath. I'm an associate professor of biomedical engineering here at Case Western Reserve University. I'll be presenting our research on RadxTools, which is an image informatics toolkit that was developed through funding that we received from the NCI ITCR program. So, all right. So why we're here today is to talk a lot about healthcare, imaging, AI, and so on and forth. And I really like this graphic that I found a few days ago, actually, which said, healthcare AI is an overnight success, which has been decades in the making. So we've seen a lot of research on healthcare AI. We've kind of seen these different eras of machine deep learning and different kinds of artificial intelligence over the last almost 25 years now. You started out predictive models about 15 years ago. We started seeing the first applications of deep learning. And then, of course, everyone is very familiar with the recent impacts and advances through the use of generative models. And we see this kind of trend showing up across a number of different areas. So you have, the number of devices being approved by the FDA, which are AI or ML enabled, also seeing a similar spike. You see investment, you see growth, you see a number of different types of companies which are coming out trying to develop technologies in this domain using AI and trying to impact different problems in healthcare. And this is not necessarily unique to healthcare. This kind of idea has been, this concept has been appearing broadly across a number of different domains. We've seen it show up for the concepts of economy, in the concept of the way work may be done, in the way war might be conducted in the future, how education might be impacted. And you start to see editorials, you see opinion pieces and so on, where they say, we should be thankful AI is coming, it's going to impact medicine, it's going to change healthcare for the better. But when I was looking through some of my some of the data in the space, some interesting points I found were that if we look at the general public, the patients, the people who are finally being impacted by the advances that are being developed in this space, a lot of them are actually uncomfortable of the idea of AI being used in healthcare. A majority of them don't think it's going to make much of a difference or even lead to any kind of improvement. They think it's actually going to be worse overall. So there's this kind of disconnect between what we as scientists, as researchers, as people working in the AI domain see or believe or would like to envision versus what the patients and the who are being impacted by the use of these technologies may be feeling. And there is a need to kind of bridge this gap. So one of the ways in which this gap manifests itself can be seen in the way we are, if we start to think about the way typical clinical workflows happen. So this here is a clinical workflow for patients who are diagnosed with colorectal cancer. With some tweaks, it can be kind of generalized to many other types of diseases as well, and cancers as well. So as you can see, patients come in, there's kind of this one-size-fits-all pathway. Patients come in, they get imaging, they undergo some kind of therapy, they go to surgery, you have follow-up management. And this is what all patients are going to go through. And this is what they're all feeling. And they're wondering where AI is going to come in to impact this. And one of the ideas that we've been exploring and that is gaining a lot of traction in the field is that there may be a possibility to try and use artificial intelligence, AI, to actually develop different types of pathways. So you could have patients getting treatment, maybe those who have complete response just go into active monitoring. those who just have regression, go to surgical excision. You can imagine there may be other pathways here for other types of therapy, so patients who may not respond to neoadjuvant therapy. And this question is a common question that is being addressed in a number of different cancers, including rectal cancers, brain tumors, which are some of the use cases that we explored in our RadxTools project. So how can we do this? So to do this, the idea I'm going to try and pitch to you is that we could start to do this by building these precision medicine tools. And precision medicine tools themselves can be broken up into kind of prognostic tools where you're predicting outcome or progression, or predictive tools where you have different treatments. You're trying to figure out which treatment fits which patient most accurately. So you're trying to predict that response to treatment. And the way we're going to do it in this talk is we're going to use computational imaging. So using all of the information, imaging data that is collected for these patients, we want to try and guide which therapies best optimized for which patient populations. And the specific types of computational imaging approaches we're going to be talking about are, one is radiomics. So radiomics is the idea of extracting quantifiable features from radiographic imaging. And then similarly, you could also think of pathomics, which is trying to use digital pathology data to identify different signatures associated with disease outcomes and progression and so on. So while that's our overall goal, there are certain key pieces that we need to start keeping in mind, right? So one is this idea of interpretability. So what we mean by this is we need to be able to figure out why the machine is doing what it's doing. And if we want to think about it, so for example, in a lot of radiomics papers and a lot of radiomics studies, you will see these very interesting looking heat maps. So it's a heat map because it's going from kind of blue to red being some kind of high measurement and blue being a low measurement. And then, they'll point to this heat map and say, oh, you can see different patterns of heterogeneity, more red, more blue, and so on and forth. And if you start to look at this in more detail, the natural question, which we've often been asked in our lab and a number of people face as well, is, well, what do these patterns mean? Like, what does it mean over here when this pattern looks like this versus what is different when we look out here? And in order to interpret what is being captured by the radiomics, we need to start to connect it to other types of data. So for example, we could go one level deeper, start looking at the pathology underlying this imaging, this MRI scan, to try and identify different tissue types that might be present in different regions, which in turn allow us to then interpret what tissue is driving what signature. So in other words, we can start to say, okay, so if we can find surrogates of these tissue changes, we have a better understanding of why the model is working. So for example, this signature is more closely related to submucosa. This here is maybe related to muscle. This is related to fibrosis, and so on and so forth. So this is one angle, the question of interpretability. The other question is the question of generalizability. So generalizability is where you want to try and build these models which are going to work in a much more generalized fashion, are not going to get stuck in any one particular situation or one particular type of data. So one of the ways I realize this is if we look at large scale studies. So this is a paper from Lancet Digital Health from a few years ago where they showed where they reported that in a very large meta-analyses, many deep learning models, and the same is true for radiomics models, have been shown to be equivalent to healthcare professionals, but in most cases they've not actually been externally validated or actually been compared on a head-to-head basis between the clinician versus the model. So how might this manifest? So for example, this here is real data. I'll bring it back later toward the end of the talk. So this is where we trained a model to identify a particular disease. This is the training set where we developed the signature. You can see how the training set has a fairly high AUC, close to 80%, over 80% in fact. And then if we take the exact same model and we tested it on a separate validation cohort, we see that the performance has completely dropped off. 0.82 has dropped all the way down to 0.48. And so this means that you're going to have these kind of disconnects between how the model is supposed to perform versus the way the model actually performs. And then you start to get headlines. AI is not really living up to its promise. Or if we try to classify chest X-rays, it doesn't actually look at the chest. It looks at random leads all over the image. So why is the model going to fail? How do we start to account for those factors? How do we make sure the model is actually going to generalize becomes a key question. So with that, I'm going to kind of give you an idea of kind of the major areas we're going to be talking about here. So we're going to talk about a lot about radiomics, pathomics, AI models to try and predict or prognosticate outcomes for different patients. We're going to try to design models which are also interpretable, so we can capture known aspects of the disease phenotypes. And then we're going to try and make sure these tools and models are widely usable, that they're robust to noise and variations for clinical usage. So to kickstart, let's get into the actual workflow. So how this works over here is that, for example, we have an MRI scan or a CT scan. That's what we have over here kind of stacked up. Or we can look at digital pathology image. This is an H&E slide that has been digitized at very high resolution. So you can take these images and you can start to extract different types of features. For example, we could apply mathematical operators over the image. We could get these very interesting looking heat maps, which I talked about previously. So we here again, red is high heterogeneity, blue is low heterogeneity, depends on the pattern that you're capturing. And now these kind of measurements can be used to separate out between different groups in the data sets. You can start to segregate between, responders, non-responders, or less aggressive, more aggressive. Could also use the deep learning approach. So deep learning would take these exact same images, but instead of extracting the features and then building a model, it kind of takes a much more integrated approach. So you have this multi-layer neural network, the image goes in, gets broken down into a number of different components so that it will come up with the final classification. Once we've done this, we need to try to validate the model performance. So how accurate is it? What does the ROC analysis show? What's the area under the curve? If we do Kaplan-Meier analysis, how well does it prognosticate outcomes? And so on. So with that idea, I'm going to launch into the first of these studies, which kind of which was studied under the RadxTools project. So, for example, this first study is in the context of rectal cancer. So we had a cohort of patients who had pre-treatment MRIs. So this is the MRI taken prior to any treatment. And then what we were trying to do is predict what happens after therapy. So after they undergo neoadjuvant therapy, how well does the patient actually respond to therapy? And the way we define response is, since in rectal cancers, a lot of patients get therapy and then go to surgery, we use that surgical specimen to define that if there's any tumor remaining after therapy. So if there's no tumor remaining, they're called pathologic complete responder, which is this blue box right here. And if they have tumor remaining, it's a non-responder. And in this cohort, clinically speaking, there was no way at baseline prior to any treatment to distinguish between these groups of patients. But on the other hand, when we take the baseline MRI scans and we extract features from these MRI scans, we actually see very different patterns appearing, emerging, that distinguish between responders and non-responders. You can see how the signature is very different for the non-responder. And then similarly, you take this exact same pattern and we start to look at it in other cohorts, and we see that that pattern tends to generalize. You can see a similar pattern for responders, similar pattern for non-responders. And this here is features, when we built them into a machine learning model, actually gave us pretty reasonable performance in distinguishing between responders and non-responders. And this feature was one of the major features that we developed through the RadxTools project. Another way we've tried to use these features is, like I mentioned previously, you can look at the digitized pathology images. So this here is a biopsy specimen from a patient with rectal cancer. So the diagnostic biopsy image, this is a digitized kind of scaled down version, but high resolution. We're able to take this image, we're able to detect where the tumor is, we're able to classify different types of cells, such as neoplastic or fibroblasts and so on and forth. And then once we do this, we're able to zoom in to those regions and start to analyze what signatures exist for different cell types. So, for example, this here image on the left is a representative section from a patient who had complete response after chemoradiation. This patient had very poor response after chemoradiation. And the different colors here correspond to different cell types. So, for example, if we looked at the neoplastic cells, which are the tumor cells, we see very different signatures. You can see a lot more heterogeneity here. Whereas in lymphocytes, the immune response, we can see, again, a lot more heterogeneity in the context of responders. And then, of course, fibroblasts, or the surrounding connective tissue, also shows you differences based on the degree of response. So when we take these different types of cells, extract the features, so some of the features visualizations here are also from those second order, third order features that we've been extracting. And then once we take it and we combine the different features from different cell types, we actually get a much higher performance. We see a very accurate signature to distinguish between responders, or TRG0, versus non-responders, or TRG3. And this is work that we actually presented 2 days ago at the College of Pathology conference here in the US. So we're able to take these features, extract them from different types of data. But now what happens if we start to look at the other MRI scans that we get from these patients? So everything I showed you so far is on a baseline image, so something acquired before any therapy. So now what happens if we look at the same patients, but now we look at them after therapy? Can we evaluate the response to therapy? So when we do this, what we actually found was we found very distinctive signatures to distinguish between the responders, which are the ones in green, versus the non-responders, which are in red. So now we can see the heterogeneity is different between them, like I explained previously. But then if you look at the wall and lumen regions, you can also see very different signatures occurring for patients who are responders versus those who are non-responders. So responders tend to have much smoother, much more regular, much more consistent looking wall and lumen regions, versus non-responders are much more distended. There's many more discontinuities occurring, which makes sense since as the tumor tends to grow in these patients, it's going to distort or distend these structures as it invades or expands from those areas. So it's kind of an intuitive feature. Combining the texture and this surface feature actually gave us better performance than using either one individually. Again, we validated this across multiple institutions. And then through the RadxTools project, we then started to expand this out. Can we start to look at other regions? So for example, so far we've been looking at the tumor, which is the primary site of where the tumor exists. So, and then you can think of this from, and most of these have all been in the axial view. But then you can also start to look at regions surrounding the tumor. So the perirectal fat. So perirectal fat is where you may have nodal metastasis, or you may have tumor invasion. So you're starting to look at the peritumor or the perirectal fat regions. And then interestingly, what we did is we didn't just look at it in one view. We also looked at it from an orthogonal view, so from a coronal view as well, because from a radiological perspective, they use multiple views when they're making their assessment. So we kind of hypothesized that from a radiomics perspective, also you would need to incorporate multiple views, multiple angles of data in order to get a better model. So as it turned out, when we extract each of these different regions, extract the signatures from them, and we put them together, that's this blue curve here, integrating information from multiple regions and multiple planes actually performs a lot better between both our training set as well as our validation set compared to any of the individual regions, which are here in the other colors. And then what we found even more promising was when we took this radiomics model and we integrated in clinical variables such as the clinical stage or biomarkers and so on, we actually found that we were able to improve the performance of finding those non-responders as well to a much higher degree. So we're basically reducing a lot of our misclassifications as a result of integrating information from across multiple planes, multiple regions, as well as incorporating the clinical features into the model. So these tools, we actually have been releasing them through this U01 that we were funded on a couple of years ago. You can see the website right here, github.com/RadxTools. So they're available for usage as Python plugins, or they can be integrated into Slicer or PyRadiomics, CapTK. So here you can actually see when you load it into Slicer, you can select the different parameters of the feature, set what kind of feature you want to extract, and then it extracts the feature, and you can very quickly apply a heat map, color map to kind of visualize it in 3D, as you're going to see in a second here. Similarly, for those surface features, the topology features that I was talking about, where you're looking at the distension or the structure of the surface, you can similarly visualize what that looks like. And over here now, green and pink correspond to how regular or distended different regions on those tumors are. And that allows us to, and this again gives us a series of measurements which can be utilized for downstream machine learning as well. And all of these are freely available as Python plugins through our GitHub, and we keep updating them to make sure that they're usable by the community. All right, so I've spoken a lot about radiomics, about different types of machine learning models that can be used for this purpose, but I also mentioned upfront that we could be using deep learning. So one of the ways that we've been using deep learning is to try and identify different structures in the MRI scans. So this is important because typically, what we have is we have our radiology collaborators sitting there and helping us make sure that we've identified the wall, the lumen, the tumor, the fat. But if we could automate it, that will allow them to then help us, instead of focusing on annotation, help us with interpretation and how to use it from a radiological perspective, use the models from a radiological perspective. So for this, we actually developed a kind of a UNet-based model, which leverages some region-specific context in order to take these MRI scans and start to identify the different structures. So here, this is the output of the model, where the output here is in pink, The blue is the ground truth from a consensus of different radiologists, and then the purple is the overlap. So the good news here is that this output visualization is almost all purple, which means that the model and the expert almost perfectly agree with each other. And we found this to be true whether we looked at the lumen, the wall, the fat, the outer rectal wall, and we actually compared it to multiple experts to make sure that, in the future we can start to use this model to do our segmentations rather than having a radiologist spend a few hours of their life in trying to carefully annotate out these structures. If we're able to do this automatically, it allows them to then focus more on how to use the model outputs and give us input on how to integrate with their scoring instead. But while that's kind of the goal, what we found is that even when you've built the best model possible, it may be that you take your data, you train your model, and then this here is kind of the ground truth provided again by a consensus of radiologists. But then despite all your training and optimization, you still end up in cases where the best model still tends to under-segment in some areas, right? So here you can see the pink is where the model has made its prediction. The green is the same as this. The green is what the radiologist said is where the tumor is. And you can see how there's some discrepancies, missing a little bit of the corners. So now the question is, okay, so is that okay? Should we have somebody go in and fix it? So, usually we'll have a student or we'll have trainees going in and just going through all the segmentations to make sure they're accurate. We said, well, why not try to integrate that input back into the model? So if we take this manual verification, feed it back into the model, reanalyze it, it turns out that now that allows the model to perform a lot closer to what we would like it to do. So you can see over here now the pink is a lot more accurate. It's picking up a lot more of the tumor without too many misclassifications. And when we validated this, we did this in a kind of unique setup. We had a training set. We had a human in the loop, if you will, set where we were optimizing its segmentations and getting human feedback. And then we have a completely separate validation set. So on that validation set, we found the model by itself was much worse than integrating human input. So this is good news overall. This says that bringing the human into the loop for even a task like segmentation is going to give you much better performance than trying to rely on the human by themselves or the model by themselves. And why the human by themselves? Well, the humans by themselves are going to take a very long time to sit there and annotate each slice individually, somewhere in the order of 40 minutes. Whereas if they are correcting annotations that have been kind of initialized by the model, which is the red here, you can see that the time required for these segmentations now drops by almost half, but the performance has, of course, gone up by a similar amount. So this may be the way to go forward, where we're integrating human input into the model so that we're able to do a better job overall of identifying structures on the images. So just like we're bringing humans into the loop, we said, okay, do we have a way to kind of integrate radiomics and deep learning models into neural networks? So this here is a very simple convolutional neural network. You have your two convolutional layers, two convolutional blocks right here. These three are three activation blocks. And if you take this very simple network and you trained it to identify where the tumor is or whether the patient is responding or non-responding, you can actually see how this network, though simple, does a decent job, but not a perfect job of identifying what's going on. So this up here, this is a patient who had complete response, a patient who had non-response. As we run it through the layers, these heat maps should kind of start to coalesce within the tumor ROI, and you also want them to ideally be different between a responder and a non-responder. You can see how it's not that different. It's showing a fair amount of overlap. There's a lot of noise. Whereas once we take some of the radiomic filters and patterns that we know to be useful from other contexts and integrate it into the model, like you're seeing over here, that's the red blocks in each case. Once we do this, we can actually get a much more sophisticated model. So now you can see exact same images go through the network, and it starts to get a lot more specific to where the tumor is. Very different signature between the responder and the non-responder. And this then allows the model to also perform a lot better. So integrating the radiomics with convolutional neural networks also allows us to do a better job than using either one individually. So I'm just going to slightly switch tracks because so a lot of the work I've been speaking about over here has been in the context of oncology, but we've also applied these in the context of digestive diseases. So I just wanted to briefly touch upon some of those as well there because it's in a related area. So the major question that we're trying to address in the context of Crohn's disease is patients who are getting who've been diagnosed with Crohn's disease tend to get this very aggressive biologic therapy, which has a very high failure rate. So a very similar problem in the context of trying to identify the right therapy for these patients. What we're trying to do is use the standard of care MRI scans to help the clinician decide whether the patient should be getting medication, should be going to surgery, should be undergoing some kind of minimally invasive procedure, and so on and so forth. So for this, we actually accrued a cohort of patients. We split them up with aggressive Crohn's disease, split them up into low and high risk. And because this is not cancer now, this is now Crohn's disease, we defined this idea of response or risk based on the need for surgery. So if a patient needed surgery very soon after the imaging scan, very soon after initiating the aggressive therapy, we said, well, they're likely a high-risk patient versus a person who's stable would be considered a low-risk patient. So what we found was that when we took these patients and we looked at their clinical factors, it was very hard to distinguish between the patients who were low and high risk or the patients who needed surgery versus those who did not. You can see a fair amount of overlap in this Kaplan-Meier curve over here. But on the other hand, if we look at the radiomic features from these regions, there are very distinct signatures associated with low risk versus high risk. We can see a lot more activity, a lot more heterogeneity in high risk patients. We then said, okay, we would like to start to look at ways to integrate this with other types of information. So one of the pieces of information we utilized was radiological scorings, where a radiologist to go in and score each of these scans as well, based on a number of set criteria. And then integrating that with the radiomics actually gave us much better performance compared to the clinical features or compared to either one of these individually. It actually identified 100% of the high-risk patients very accurately, which is what the clinicians are most interested in, and could also even prognosticate kind of time to surgery, so which would be important for the clinician to decide what they should be doing with these patients as they go forward in their clinical path. So as I mentioned up top, I said, I'm going to be showing you a lot of different types of radiomic signatures and different types of patterns. And one of the questions is, how do we start to exploit the pathologic association? How do we start to understand or interpret pathologically what may be derived by these radiomic approaches, by some of the tools we developed through this RadxTools project? So for this, we need to start to marry the imaging that you're seeing over here as a radiomic map with the underlying pathology, which you're seeing over here as the H&E image. So is there a way to start to marry these two together? So for this, another set of tools we've released through the RadxTools project is this radiology-pathology fusion tool. So this is a notebook that is freely available for people to use. You're able to load in the MRI and the pathology data. It allows you to do some basic interpolation and manipulation of the data set. So you're able to identify, make sure that they're in the right alignment, that they're correctly scaled with respect to each other, because these images have very different scales and resolutions, as you can imagine. And then once you've manipulated them to be in correspondence, what you can do next is you can actually go in, and this is happening almost essentially in real time. You can select corresponding locations on each of these images. Now, this of course does require some clinical or input to understand what should go with what. But over here, we're kind of lining up those dots. Each of those dots, the colors correspond between the two images. You can actually go in and fix any of those dots, those spots, if you don't think they're very accurate. And then what the model does is it's able to line up those spots. It warps the images into alignment so that you can actually get this almost real-time visualization of how well the two modalities line up with each other. So again, over here, you can kind of see that overlay between the MRI and the pathology, and then that allows you to start to map tissue types between MRI and pathology. So we've used this in a number of different contexts. So one of them is just to close the loop on some of the Crohn's disease work. So one of them is in the context of Crohn's disease. So for Crohn's disease, we got this matched set of pathology and radiology data. So this was MRI scans from patients who went to surgery, and we have surgical specimens within a few weeks of the MRI scan. So we can essentially map the two onto each other, allows us to define signatures. In this case, we explored the concept of inflammation. So we can kind of use the pathology data to define low and high inflammation. This is important for selecting anti-inflammatory versus anti-fibrotic therapies. What we found was that we could actually identify distinct radiomic features to distinguish between this low and high severity. We could then integrate this with radiological scoring to actually get a very accurate prediction of which patients had severe inflammation, which is very critical because those are the patients who may not necessarily respond to just routine anti-inflammatory therapy. We similarly did this in the context of fibrosis. So here we again, mapping these specimens onto the corresponding MRI scans allowed us to then define specific signatures which were different for severe fibrosis. So we have severe fibrosis at the bottom, so it's a different set of features and a different signature associated with fibrosis. And then we were also able to try to connect the dots to say, okay, what types of specific aspects from a pathological scale are actually driving this radiological signature. So we could actually find that there were features associated with mucosal fibrosis or subserosal fibrosis, which were more closely linked to the radiomics compared to any of the other aspects. And that allowed us to then take that information and build a better predictor. So this is one aspect. One is to essentially map it and try to correlate it, but can we do more? Can we try to use pathology to actually derive specific features from a radiomics perspective? So for this, we looked at the underlying pathology, and one of the things we realized, and this is in the context of rectal cancer, one of the things we realized is that each of these colors here on this pathology image correspond to different tissue types, and there seems to be this kind of interplay and spatial interaction occurring between the tissue types, which makes sense. As a function of treatment response, we're going to see those tissue types changing and morphing. So you may have the tumor dying out, being replaced by fibrosis. You may have residual disease. You may have inflammation, and so on and so forth. And so if we were to take those features and start to look at the radiomics instead, what we realized is if we took the radiomic map and kind of partitioned it into different expression levels. So you have high expression, so that's a red, low expression, which is the blue, and then medium over here. You can actually see, if you squint, you can actually not only can you see some correspondences, but you can actually see that there may be connections that are similar in terms of the spatial interplay of the radiomic compartments, which parallel the interplay between the pathologic compartments that I was talking about up here. And so what we did for this, to quantify these interactions, quantify the interplay, we actually built a graph. So this is a very simple graph that we built over here, but this can be made more complex as well. And that allows us to derive a signature which captures the interplay of different compartments on the radiomic scene, which is intended to be a surrogate of the interplay of different compartments on a pathologic level. So when we tested this actually both in the context of brain tumors as well as rectal cancers. So when we looked at patients with metastatic disease versus those with no metastatic disease, we actually found very different signatures between metastatic and non-metastatic. Not only do the heat maps look different, but if you look at that underlying spatial interplay, there's also a significant skew in the context of metastatic patients because there's a lot more red and yellow compared to the non-metastatic patients where there's also some kind of the blue compartment is also existing. And this, of course, validated across multiple institutions. So we looked at a different institution, we found the same kind of skew showing up. So this feature, then we tested it for its complementarity to existing radiomic models. We found that it is quite complementary. It actually boosts the performance overall compared to using radiomics by themselves or this new feature that we call radistat by itself. So that's great. But the real question we had was, okay, so we're seeing the skew in the different tissue in these histograms, if you will, of the spatial interplay. What do those represent? So for this, we actually went back. We said, okay, let's look at we have the heat map from the MRI scan, which is this blue, red, and yellow quantized heat map. We have the corresponding skewed signature. Metastatic patients have a lot more red and yellow interactions. Non-metastatic have interactions with blue as well. And then we basically took these and mapped them back onto the pathology and looked at which tissue type lined up with which color or which compartment over here. And what we found was, in general, the blue tended to overlap more with fibrosis regions, whereas the red tended to generally overlap with cancer regions. And now this kind of makes intuitive sense because metastatic patients are likely to have a lot more tumor, and therefore that's driving the interactions there, versus non-metastatic patients who are responding to therapy are likely to develop fibrosis, which then drives the interaction on that scale as well. So this was kind of a nice example of where we started out with a set of data, and we would not only develop the feature, but further validate and interpret what that feature might be capturing. So along these lines, we said, okay, can we actually extend this idea? So we looked at spatial changes. Can we also look at physiological changes? So for example, we have these patients over here. I showed you a version of this visual earlier, where I said, non-responders tend to be a lot more discontinuous. There tends to be a lot more disruption of the wall and the lumen and so on and so forth. So what if we could start to quantify that in a more detailed fashion? So for this, we actually built an atlas, a canonical representation, if you will, of what the rectum would look like. without any tumor in it, and then essentially mapped these two onto each other to get this deformation map, which again we released through our RadxTools project, where this deformation map is actually, if you look carefully, has a number of arrows on it, and the arrows correspond to how the whole organ is kind of twisting or deforming as a function of response. And you can start to quantify information from this. So you can look at how much deformation there has been. So is it more, is it less? And you can also look at what direction the deformation is in. Is it inward? Is it outward? Is it contracting? Is it expanding? What's going on? You can derive different types of features from that. So once we extract those features, if we look at the differences between a responder and a non-responder, what we found was that responders tended to have a lot more deformation compared to, non-responders tended to have a lot more deformation compared to responders. So you can see the blue over here in a responder, much more regular. Deformations mostly going inward versus non-responders tend to be a lot more chaotic. Deformations going inward, outward, in every direction. And those show very distinct differences between the two groups. And then, interestingly enough, combining them with the previously shown radiomics, the heterogeneity markers, actually give us better performance overall in terms of identifying complete responders after chemoradiation. We actually have this work that's currently under review at an NPJ journal. But then we said, okay, we have this. Are we also able to then identify other aspects? What else can we do with these markers? We actually were able to test it in a clinical trial data set. So this was actually a unique clinical trial of patients with rectal cancer who got chemoradiation, but also got some experimental immunotherapy to try and boost the efficacy of chemoradiation. And then these patients were then, based on the follow-up for these patients, we could kind of segregate them into responders and non-responders based on whether they had sustained response or they went to surgery and there was no tumor remaining. And what we found was that when we looked at this early time point MRI that was taken about 15 days into treatment, post-treatment scan but taken a few days into treatment, what we actually found was, again, responders and non-responders tend to have very different signatures. You can again see responders being a lot more regular, non-responders a lot more irregular. And then that actually allowed us to separate out the two groups. So again, over here, red are the non-responders, green are the responders, and we could actually identify those groups with a fair amount of accuracy. So just in a completely unsupervised fashion here, so we didn't actually train and validate, we just applied the metrics to separate out between the groups. So in this clinical trial data set, also we're seeing similar signatures show up. And then because this was a clinical trial, they had collected additional data, we also had access to biopsies. So when we correlated these against biopsies, we actually found specific aspects of the immune microenvironment were driving the signatures that we were deriving using this whole deformation framework that I just presented. So with that, I'm going to move to the last part of my talk, which is to do with the generalizability concept. So just to remind you guys, why we care about generalizability is, garbage in means you're going to get garbage out. So if you're going to have machine or deep learning models which are exposed to data which have a lot of artifacts and so on and forth, such as aliasing and noise, the model may not actually generalize it. The artifact may actually end up confounding aspects to do with cancer recurrence. It may end up, you have a data set out here. This is the first data set, you train it, and then you go to a different data set and it completely does not validate. So now the question is, how do we start to quantify, characterize information over here? So for this, we actually developed a tool which is applied for quality control of different types of both MRI, and more recently, we've actually updated it to also do CT. So the way this tool works is it's a completely it's a Python package that can be run offline and then comes with an HTML interface that can be locally run and can in a very rapid fashion go through a large cohort of data to analyze different types of information. So this is just a visual of what that front-end interface looks like. So this is completely locally hosted in a Chrome browser. You can see over here, you can run it in any browser. So you have different tables. You have tables of the different metadata. You have tables of the different measurements that are being extracted. It's completely interactive. You can select patient in any one table. It highlights throughout. You also have different visuals. You get a coordinate plot to kind of visualize the trends across the cohort. You can also look at these kind of bar plot trends to identify the outliers. So for example, some of these you can see there are more outliers and less. Visualize the images. And then you can also do a scatter plot of the images. So based off all the data, we kind of project it into a 2D space to show you what clusters may be present. So here you can actually see this particular cohort has 3 distinct clusters, 3 or maybe 4 distinct clusters showing up from the raw data. So if we were to take this raw data and try to train a model, it may not perform as well because we have very distinct batches or groups in the cohort. So we actually have tested this on a whole host of different types of data, including publicly available PCIA datasets across multiple organs. So this is, I'm showing you data here from brain, which we tested in prostate, rectal, kidney, ultrasound, breast, cervical, many different cancers and conditions, as well as digestive diseases for that matter. And what we found was that using our tool, we're actually able to identify not only different artifacts that may be present. You can actually see a specific outlier that was identified through the tool out here, which was important to correct. And then we also found that we're able to distinguish between different institutions. So for example, over here, the different colors correspond to about 7 different institutions of the TCGA GBM cohort. You can see how the RAD key or the marquee results actually distinguish between them quite significantly, which would suggest that if you were to train on this cohort and test out here, it may not actually generalize as well. And then using the tool, you can actually start to apply the appropriate corrections to ensure that these images are better harmonized prior to any analysis. So this is step 1, is to try to correct sources of error that may be present in the data. Step 2 may be that despite all of those corrections, there may still be differences between radiomic descriptors because of the underlying differences in the magnetic field strength or the voxel resolution or imaging parameters. So same different patients, 2 different scanners, but the same feature has completely different appearance between the 2 institutions, right? So in other words, each of these, despite all of our harmonization up front, it may still mean that the features are not very robust to imaging changes. So we try to figure out what this may be like. So for this, we actually ran a prospective study. We collected data prospectively in a very careful fashion. So these were all taken from healthy volunteers. We got essentially healthy brain MRI scans. But each volunteer, what we did was we had them sit in there. We had them sit in the scanner or lie down in the scanner. And then we essentially fixed a whole bunch of other parameters and varied only one parameter at a time. So we fixed all echo, resolution, everything else, varied only the repetition time, then did the same for echo time, then did the same for resolution. So we could, in a very controlled fashion, analyze how each imaging parameter is affecting the radiomics and which ones the radiomics is more or less resilient to. And then we did a whole host of different types of analyses, annotation differences, different statistical comparisons, also looked at what happens if you would correct the data and then run the analysis, how much does a correction actually help in this context, and so on. And the results were kind of interesting. So we found that, a lot of the second order features, a lot of these co-occurrence type features were actually pretty consistent if we looked at variations in echo and repetition times. In other words, contrast differences in the images. You can actually see pretty consistent signature here for this heterogeneity feature, whereas some of the more edge-based features or some of the more pattern-based features may be a little bit more inconsistent. You see very slight differences, which is enough to cause these to be very different heat maps. I would say the more concerning result we found was actually in the context of resolution. So this here is the same feature at 5 different resolutions and 4 different resolutions. You actually see the feature changes quite a bit in each case. So in other words, not correcting for resolution could hugely impact some of these features. And if you appropriately process the data, you would see some consistency, at least for some of the features, especially wavelet features, were pretty consistent after applying some processing, but many other features were not. So step 1, we looked at differences in the data. Step 2, we've looked at differences in the radiomics. If we fixed all of this, ideally our models should now generalize, right? And so this is where the model optimization comes into place. So over here, this is some data that I had shown you up front as well, where if you take 2 different, so this is 2 different data sets, D1 is training and D2 is validation. The top row are patients who are considered, I think, either responders or healthy. The bottom row are patients who are diseased. And you can see how in the training set, despite all of the processing and optimization and so on and forth, you can actually see in the training set, very distinct signature. The blue pattern corresponds to the healthy patients, the red pattern corresponds to diseased patients. And if you go to the validation set, you can see it completely flipped. So now red is healthy and blue is diseased. And you can also see that in the violin plots. And as you can imagine, if you were to take this type of data and try to run a model with it, you get that exact drop-off that I described up front. So our model initially had a performance of over 80% and then drops off to under 50% in validation. So despite all of our processing and analysis, we actually do have this kind of discrepancy in generalizability. How do we address it? So paper that came out late last year, where we actually came up with a framework to try to analyze feature reproducibility in multiple contexts. So if you think of it, feature reproducibility or the generalizability concept can be thought of along two axes. So you have one axis here, which is how good a feature is. So up here is high. So those are good features. They distinguish between groups. Down here is low. They're not very effective in distinguishing between groups. And similarly, along this axis, the x-axis, you have how reproducible the feature is. So out here, these are features which are more reproducible. And out here, these are features which are less reproducible. So if you were to think of this trade-off, you ideally want features out here. So you want the features which are in this A or C block, and you really don't want features from the E block, essentially, right? So for this, what we have to do is we've got to go in and we're going to start to test each feature. You want to keep the features which are inconsistent, keep the features which are consistent, get rid of the features which are inconsistent. But however, the key piece here though is you cannot just do it on any one aspect. There are actually multiple pieces related to the acquisition, the annotation, the batches, all of which need to be accounted for to get a coherent, consistent set of features. So when you do this, you actually see a very distinct difference between the healthy and the diseased patients. You can see that the diseased patients now have a very consistent high signature between the two training and the validation cohort. And that, of course, also appears when it comes in the context of the AUC. You can see how the red bar, which is what happens once you account for different aspects of variability, tends to be much higher than the blue bar, which is when you don't account for those aspects of variability. But looking at this, we said, okay, this is great. We're able to do this. But now, going back to this for a second, if you have multiple types, how do we know where to set these cutoffs? Like which features make the cut and which features do not? So for this, we said, okay, we can actually build this into a complete machine learning platform itself. So we actually formulated a novel cost function, which allows us to not only optimize for how good a feature is and how to make sure that we pick the most sparse, the most unique set of features, but also ensure that the features are as reproducible or have the least variability as possible. And we call this a variability regularized feature selection. This is a paper that's currently under review, so using this formulation, you can actually start to optimize for each of these axes. So you can actually pick the best trade-off in discriminability, in sparsity, in variability. So when you do this, you actually find that the VAR-FS approach, the variability regularized approach, tends to do a lot better than the existing methods that are out there, which include MRMR or Lasso or Wilcoxon-based feature selection schemes, even if you incorporate some level of reproducibility into those methods. And if you do some more analysis, we actually found that the reason this works so well is because the VAR-FS scheme is able to identify the features which kind of fall along the boundary, right at cutoff, and is able to optimize for this across multiple types of multiple aspects of reproducibility. So this here is discriminability out here. The CB and IS are each in different variability measures. You can see how the VAR-FS scheme is actually able to pick up features which are fairly discriminable, but may not necessarily make the cutoff on other axes, but do provide enough consistent performance that they should be included. And also the features picked up by VAR-FS actually are picked up by other feature selection schemes. So it kind of represents the best of all worlds as well. So with that, I'm going to just bring my talk to a close. We've spoken a lot about computational imaging, the number of tools we developed through the RadxTools project for interpretability, fusion of radiomics, pathomics, radiology-pathology data, and then also we had the opportunity to develop specialized tools and packages to evaluate the generalizability of imaging, of radiomics, of the models to ensure that they are as consistent and and work as well as they can across multiple institutions. This, of course, none of this work would, of course, be possible without the funding agencies that make all of it possible. And this here is the excellent team that I work with. Like I like to say, they do all of the magic, and then I get to stand here and tell you all about it. You can find more of our work on our GitHub. We have a specialized GitHub for RadxTools, and then, of course, my own lab GitHub as well. And then my email address is on the screen for anyone who would like to get in touch for collaborations or discussions as well. Thank you.
Okay, excellent presentation. Thank you so much, Dr. Viswanath. I am just checking here in the chat. Also, anybody feel free to unmute if you have a question and you'd like to ask that now. We have a bit of a quiet group. You must have answered everything in your presentation. Again, there is, let's see, he's got his email there, and please feel free to email me as well, and I'm happy to make that connection. I'm also able to share this recording should you be interested in it afterward. Okay, if there are no other burning questions at this time, we will go ahead and conclude the presentation. I just want to thank you again for attending this webinar today, and a special thank you to Dr. Satish Viswanath for being here today and providing this overview of RadxTools.
Excellent. Thank you so much, Kayla, and thank you everyone for joining in.